Hi, everybody, and welcome back to Thursday Rounds. The land that most of us are gathering on today are the traditional territory of the Haudenosaunee and Anishinaabe nations. We must do more to learn about the rich history and current lives of these nations so that we can better understand our roles as residents, neighbors, partners, and caretakers, which will guide our thoughts and actions on this land, and to address historical and current injustice in all of its forms. One next step could be reading books by Indigenous authors. I'm going to put a link in the chat to a website called Good Minds, and it provides a way to shop for books written by First Nations, Métis, and Inuit authors. There it is right there. I'm currently actually reading Braiding Sweetgrass, and it's a really interesting story about one woman's journey to blend Indigenous wisdom and scientific knowledge through the teaching of and interaction with plants. It's kind of a series of stories and reflections. Next, I would like to introduce our speaker. So we're very fortunate today to have Dr. Alan Abbas. He's a professor of psychiatry and psychology and founding director of the Center for Emotions and Health at Dalhousie University in Canada. He completed a medicine at Dalhousie University and his residency in family medicine, and has worked as a family physician and emergency physician. He completed a psychiatry residency at the University of Toronto, dedicating his career to teaching and researching the impact of emotions on health. Over the last 25 years, he's become a leading teacher and researcher in the area of short-term dynamic psychotherapy and has provided over 350 invited presentations and over 300 publications, including his first two books, Reaching Through Resistance, Advanced Psychotherapy Techniques, and Hidden from View, Clinician's Guide to Psychophysiologic Disorders. He has both been a lead and co-author of research into intensive short-term dynamic psychotherapy for treatment-resistant depression, personality disorders, and somatic symptom disorders. And he's received a number of awards, including the National Teaching Award in Psychiatry. In 2018, he was named the David Mallon Visiting Professor of Psychotherapy at the Tavistock in London, and he is the current president of the International Experiential Dynamic Therapy Association. Today, his talk is called Intensive Short-Term Dynamic Psychotherapy for Functional Somatic Disorders, Applicability, Techniques, and Evidence Base. Today, we will not be recording this talk, but there may be some resources that we are able to distribute afterwards. If anyone has any questions for Dr. Abbas, then please submit them in the Q&A or chat widget at the bottom of your screen, and we're going to take them up afterwards. So right now, I'm going to turn everything over to Dr. Abbas. Again, thank you so much for being here today.
Great. Well, thanks very much for having me, and a special hello to friends and colleagues who are up there. So pleased to present a bit about this treatment approach for functional somatic disorders. And the objectives are to be able to describe the evidence base for this approach for functional somatic disorders, name the discharge pathways of unconscious anxiety, which themselves are somatic symptom sort of formats, and describe psychodiagnostic tool used for this method to determine treatment pathways. So I'm going to just describe a bit of the burden of the condition, talk about some more quasi-conscious factors and this approach, and talk about three main categories of anxiety format affecting the voluntary or striated muscle, smooth muscle, and cognitive perceptual fields. So functional somatic disorders are a broad spectrum of conditions, and they can affect each system of the body, from basically everything between gut and skin and everything in between. And it can be with structural disease or on their own. So in other words, a person can have cancer and have functional somatic disorders, or can have active Crohn's disease and also have other functional components. And these problems, functional somatic disorders, can worsen existing structural disease, or certainly make a very confused picture. And it's a real challenge for for physicians trying to assess what's what. And that's where, psychiatry, psychology, and people with special interest in psychophysiologic processes become key in the medical system to helping medical colleagues decide about treatment processes or provide direct treatment. These conditions are a huge burden on people and on the healthcare system. Up to half of family physician visits and med-surg consults. A study we did found one in 6 emerge visits at least were unexplained symptoms, and mostly all functional somatic presentations, including 3/4 of chest pain and almost 90% of abdominal pain. So extremely common in these presentations. Huge disability costs in the country, and disability and burnout in health professionals is linked to working with populations and also having these type of symptoms themselves. So on an evaluation we did, we found it's about $24 billion a year between disability and medical service use, $650 per person. That's like every man, woman, and child in the country. So it's a massive burden. As a collective, it's relatively under-recognized, under-addressed. People go on miserably in their lives without access to services. And I can tell you, when I've done, I don't know if any of you heard that, I did a presentation on white coat, black art, and CBC radio. Every time I do anything like that, or the piece that put in the Globe and Mail a couple of years back, there are like over 100 requests for treatment. People ask about training too, but mostly it's like people telling me these terrible stories about their child or their niece or someone that is having these long-standing suffering symptoms or hospitalized, and what resources can help them out. So it's a big burden. This is just a study of consecutive referrals in these specialty clinics, and it's very common to have unexplained symptoms. So what causes functional somatic presentations, functional somatic disorders? You can think first about this as a sequence where random symptoms occur, as they happen with all of us all the time. We have a body, we detect various sensations, we get a random symptom. It somehow activates a fear of injury or death or something being terrible. It leads to anxiety, fear amongst family members, and also sometimes physicians. And it can result in sort of a learned symptom pathway, a brain process whereby the person keeps remembering, repeating the same symptoms over and over again. It becomes a vicious circle up here. You can think about it on a different level too, that the meaning of symptoms and death and all that relates to threats of gain or loss. So it's a state of insecurity. And this activates feelings about interrupted attachments and other trauma of the past. And that has its own sequence of problems. And if a person has enough interrupted attachments and trauma and other predisposing factors, they're going to have a tendency to alexithymia, inability to identify and process feelings, and also have some hereditary, or not hereditary, but developed tendencies of autonomic nervous system responses. So add this together, you have a sequence of processes that can go on somewhat unconsciously or sort of more at a core structure, and others that can operate more, if you want to say, quasi-consciously. So you can think of it this way, that sort of the more obvious things that a person can tell you about sit more at the top, and the other things can be further out of reach or harder to see. And so if you think about it, then you're going to have a different approach to this top part than you're going to have to this bottom part. And this top part here, I'm not going to spend time on this, but the solution is a thorough assessment, a therapeutic alliance with a doctor, and education to say, carry on. You don't have to worry about this. Go back and do everything you weren't doing before, and and just to unlearn that cycle of symptom formation. So that's kind of like, you feel like an exposure approach with some education. And that should resolve that top end part. Now, when there's more sort of emotional components or like a core problem around emotions or autonomic system tendencies that are there, that are more out of reach for the person, then other processes become necessary, and the person will tend not to respond as well to education, reassurance, and exposure, and cognitive processes as well. You can add cognitive therapy approach elements here, just around undoing the fear and changing some of the thought patterns and behavior patterns. So what about the emotional contributors then? So this approach from intensive short-term dynamic psychotherapy, I think of it as a tertiary approach for psychotherapy for people who have not responded to first, second, even third, sometimes third line medication treatments and psychotherapy. So it's built for people who don't respond to other treatment efforts in general. So what's it about? It's really around attachment and the impact of attachment and how that interruptions of attachment lead to basic physiologic tendencies or pathophysiologic tendencies to respond in adulthood with somatic symptom formation, as well as behavioral problems and a range of other symptoms. So when there's an attachment that's been interrupted by some kind of trauma, neglect, abuse, something happening to interrupt it, it results in a cascade of feelings, including fear, but also rage towards that attachment figure. Okay, so here's an example of attachment trauma. Mother dies at age 2. That kid has got all this painful feeling and rage often towards the mother who died, and has also intense guilt about the rage. So the kid is stuck with all these complex feelings, and resulting in a range of symptom formation, symptom complexes in childhood and adulthood, behavioral problems, personality dysfunction, and then grow up and end up in involuntarily replicating the same process with their own children, not necessarily by dying, but by interrupting the bond with their own children, because those same feelings get activated at the same age of their own trauma. I'm going to talk about a case later who, at age 4, she was taken by Children's Services because of severe abuse she was going through. And then when she grew up, and then when her daughter turned 4, she totally decompensated with severe anxiety, collapsed into severe depression, and her own daughter is taken away at the same age she's taken away. So these type of things are actually quite common and disastrous for the next generation. So when you treat a person to deal with their childhood trauma, you protect the next generation too. So how do these bunch of complex feelings show up then? First, these feelings get reactivated in current attachments. So with you in the therapeutic relationship or the medical relationship, and with current people, these past feelings get reactivated. And again, this is something we all do. It's a normal phenomena of transferring or assessing people based on life experience. But what happens when those old mixed complex feelings get mobilized from the past attachments in the attachment with you or the doctors? Is it activates unconscious anxiety which the person is not aware of, and defenses which the person is also not aware of, or we call unconscious defenses, or habitual ways of avoiding. And there's languages in these for this in other modalities, by the way, and I'm sure many of you use the cognitive behavioral therapy model. We just published a paper, Nate, Toma, and I, on kind of a bridge paper between CBT and ISTDP. It's just, I'm not even sure if it's out there in paper format yet, but it's just been published. So there's ways to talk about this in different modality and language and cognitive behavioral language. So, so these feelings are coming up, making unconscious anxiety and avoidant habits with you in the room or with current people in life. Well, that's all interesting, but how do you actually determine this? How do you evaluate this to, to tell whether or not this is a factor for your person, your patient sitting in front of you. And that's when it comes to an active psychodiagnostic assessment. So what we do here is actively focus on emotions that the person has anxiety about and watch their body response and watch the defensive response. So you observe how they react to a focused interview. So here's an example. The person comes in my office and has some nervousness, and they are somewhat tense coming into my office. And I say to the person, I notice that when you're coming in, your body has a lot of tension in it. Is that something that you're experiencing? And the person says yes. And I say, so can we take a look together to understand what drives that? What produces the tension? And they say, yes, sure. So I say, so what feelings come up to make your body go tense? And so as I'm doing that, I'm asking what emotions make their body do this. And what you see then is a rise in tension. So the person's hands tighten, they have sighing respirations, okay? And you're seeing that with a focus on feelings, anxiety goes into this channel, which is called the voluntary muscle channel or striated muscle channel, very specific format, pathway. And you'll see that they get a rise in tension when you ask about feelings, and they're not able to identify the feelings. Instead, they just get a body tension, and often that is their entire symptom problem. So if the person has, for example, fibromyalgia and chronic muscle tension, spasms, tremors, some tics, tension headaches, these phenomena are often tied tightly to anxiety in the striated muscle. And by helping them recognize that and identify and feel the feelings, the tension drops, the symptoms drop, and that's your diagnostic information and treatment. At least treatment's beginning. For some people, one session is enough to bring down the symptoms. Other times is more. So that's just an example of psychodiagnostic. So there's three main patterns that you'll see. This one is tense up and tend to detach and distance and avoid in the room. So an example of that is if I ask the person, I say, I notice your body's tense. Can we look at, see whether that's contributing to all this pain in your shoulders? Okay, that's an example. And I say, so what feelings are rising up? And I ask about emotions. As they get more tense, they start to break eye contact and distance themselves away from engaging with me. They do it as a habit. They do it all the time. When emotions come up, they tense up, wall up, and detach and distance themselves and never get to feel anything. They just distance from people and cut off closeness in relationships. So you help them see that. When they start to do that detaching and avoiding, we help them observe that they're doing it so that they can recognize that that's interrupting the ability to understand the problems. And it puts up a barrier and it hurts them in some way in their life and also in the room. Then they fight it and they don't detach and let emotions be present and let themselves feel feelings. And when they do that, then they can see the impact of that on body symptoms they're coming in with. So that's just a little snapshot. By the way, the teaching we do on all these things is all video based. So it's so whenever we teach on this, we show video on video to show whole sequences of interviewing and patient response and body responses, but limited here in this format to do that. So I'll just describe them. So that's the first pattern. The second is the person goes flat with smooth muscle anxiety, which is in the gut, blood vessels, airways, and bladder. Okay, that muscle is involuntary, you have no control of it. It does what it does, the stomach does what it does. And instead of tensing, the person will develop cramps in the stomach, nausea. You can hear bowel sounds in the interview, or they get a bladder spasm, or they start to flush, change in blood flow, change in blood pressure. And so what's happening then is that this situation, you can't just go and start focusing on feelings because the person's getting body symptoms that are a problem. We have to regulate anxiety, do things to settle the anxiety, and build it up in what we call a graded format. And I'll describe this a bit later again. But you have to go more in a graded way or gradual way here. You can't just directly move to access the feelings here. So they need capacity to become capacity building first. The third group is similar in that they need capacity building first, But the third pathway is that the person, instead of tensing up and defending, the person gets blurring vision, can lose their hearing or strange hearing sensations, get totally confused, can lose consciousness, can have functional seizures, can lose sensation in the body. So these functional neurological type of symptoms are seen, again, when those are active, there's no tension in the muscles and the person is not able to intellectually observe what's going on. The head is not working and the muscle tone is flat. So three different diagnostic looks and the treatment pathways are different. And so I was going to say something about the evidence base for this approach, that where this is coming from, to say that for somatic symptoms, there's about 25 outcome studies. There's evidence that these are sustained or increase in follow-up. It outperforms CBT in 3 chronic pain studies in a meta-analysis we did. And emotional focus is important in the treatment outcome in a process study we did. So these are the type of studies there are for all this spectrum of physical conditions here. Case series, randomized trials, and cost effectiveness studies. So you can see the neurological is there, the jaw pain, spasm, fibromyalgia, pelvic pain, urethral syndrome, general chronic pain, mixed conditions. For the this is a study we did in emergency department in Halifax, and we saw a nice drop in emergency use and follow-up compared to the year before and compared to a comparison group, and the treatment cost was offset by reduced emergency use. So this is a Canadian leading practice program, this format, something that really should be used in bigger emergency departments, because there's so many people sitting in that waiting area that are just going to get a no diagnosis and go home after. We might as well get them into the proper channels, which is psychological treatments. So we did a big cost study, 890 patients, 58 therapists. So these are me and 57 people I trained over years, and self-report measures all improved significantly, and 12,700 per patient reduced healthcare cost in 3-year follow-up. So this is what we saw on doctor and hospital costs and follow-up compared to a comparison group, and it was a significant cost offset. Most of these people were functional somatic problems. This is a subgroup of that data with functional seizures, and you can see it. This group is a high using population, 23,000 a year, and there's an RCT of ISTDP for functional seizures that's in press right now. Pardon me. And there's a couple of case series otherwise on functional neurological disorders, and was one on functional movement disorders. This is data from here on chronic pain. Again, patients go down to the normal population in follow-up with significant symptom reduction. This is an RCT of using mindfulness-based stress reduction compared to ISTDP. And ISTDP outperformed MBSR in the follow-up in weeks 6, 7, 8. There's 3 RCTs using ISTDP versus CBT. The first one here there's no significant difference. There's a little bit lower effect here, but it's not statistically different on that study. But the other 2 studies showed a difference for ISTDP. When you add the 3 studies together, you get an effect size that's significant for pain and depression comparing to CBT. And this is other studies sort of within group effects are robust, except for interpersonal problems, but these are general pain, anxiety, and depression. So, there's just to say the CBT thing, the margins of the confidence intervals are is significant, but the heterogeneity is wide for people that know about meta-analyses. So it just means that, you know, there's some signal of maybe some difference in outcome here, but you don't want to put too much weight on that. At least it's in the ballpark as being at least as effective as CBT, which has much more number of studies. This is one we're just having preparation on the emergency department, and it's so this is it's not yet published data. This is using the SOMS, and this is the ISTDP group, and this is the comparison, which is medical treatment as usual. So it's a significant difference. And just to say, because you know you're a psychiatrist and as a mental health system, I mean, there's studies of using this as an adjunct in psychosis and bipolar disorder with good evidence on cost effects. These are all published studies. There's 3 RCTs in depression and evidence of cost effectiveness compared to controls, compared to treatment as usual. I mean, there's RCTs of personality disorders, RCTs of anxiety disorders. And on an inpatient ward, we implemented it. It brought a 65% drop in ECT use. So you use this to prevent the need for ECT, and it actually paid for the psychologist to have the less ECT. This is something that I'm not sure why hospitals aren't clamoring to bring this onto inpatient services so they can reduce ECT. I'm not sure what that's about, but it's I'm not sure what it is. Maybe if someone can explain it to me, I'll appreciate it. Maybe you guys have less ECT use over there. I hope you do, because you know it's one to be used when we need it, and otherwise we do talking treatments whenever we can. So obviously, so there's studies of use in new learners. So just to say, well-researched approach. So, so talking about these pathways again, and again about treatment process. I wonder if we should take questions for a minute before we go further. Is that okay?
Sure, we can certainly do that.
I hit the Q&A button.
Well, it'll show up in red if someone has a question. So if anyone has a question for Dr. Abbas, you can certainly enter it now, either in the chat or the Q&A.
I'm going to just describe the treatment processes a bit from here on, a bit more on these different patterns, and talk about physiologic pathways of emotions too.
Okay, looks like so far no one has any questions. I imagine they're waiting for that piece maybe. Okay.
So this striated muscle pathway, as I mentioned, it actually goes up the body. Sorry, it goes down the body from the top. So it starts on the thumbs and the neck and goes down. And at some people, it goes up into the jaw and head as well, but otherwise it's going down. So it builds with hand clenching first, then it hits the intercostal muscles of the ribs, and then there's sighing respiration, it goes back, legs, and feet. So you can imagine that if someone has chronic tension in these areas, they could have psychiatric symptoms of hyperventilation and panic attack, but otherwise it's going to be functional symptoms of the chest. And then pains, spasms, headache, tics, tremors, and all those various things that affect those muscles. And as far as treating this component is really help the person identify and feel the feelings that they're tightened up about. And as the feelings emerge in the body, they displace the tension at each level of rise up the body. So for example, if a person has a tense abdominal wall, when the rise in feelings come up to the chest and they have anger coming up to the chest, their stomach now no longer has tension in it, and they notice the pain has dropped. If they have chest tightness, if it gets up to the neck, they notice that their chest is now free to move. If they have a lot of pain on the neck, then the feelings of the emotions have to get higher up in order to free up the neck. So the feelings have to get up through higher level to move through the tension component. So if I were able to show videos, I would show you a first person who came in with a whole lot of pain in her neck and her shoulders are raised like this, and she's in a court case with a relative, and this chronic pain on the neck. And as we focused on her feelings about her relative who was suing her, she felt this heat energy build up in her body as the anger's coming up. And as it got up into her neck and her shoulders, it's like all of a sudden she realized she felt like just grabbing the guy by the neck. And as she felt that in her hands, okay, she said in the middle of it, she said, I'm just like amazed. It's like, where did the pain go? It's like all of a sudden I can, it's gone. But now she wants to put pain on the other guy's neck, okay, her relative. And then there's a terrible guilty feeling as if she just did this to the guy just by feeling it, okay? Now from there, her body and mind is in a very relaxed state, and she just felt this guilty rage break through with her relative. And next thing is she's immediately thinking of her father when he was aggressive when she was a little kid, and she never got to face those feelings either. She became a tight, nervous little girl. And so those emotions come through. And this is a person who was on a high-dose narcotic, years of symptoms, years of treatment, who responded to a total of 12 sessions of this treatment spread out over a few months because she had long distance to travel. So she's an example of someone that if I show you the video, you see the person goes from very tight, all clamped up to right at ease, pain gone down, and understanding what's been going on. So that's the voluntary muscle component. The second case example is one that was mentioned in the Globe and Mail article, is a person who had aphonia, no ability to speak, and had functional aphonia. Like the neurologists and ear, nose, and throat people saw her, and she had vocal cord spasm. It wasn't able to move. So in the first session, with focusing on the emotions, there's a rise in the feelings coming up. And as they got up to the neck level, she was talking about, one of her relatives who was threatening to her. And when she felt this feeling go through and the urge to do something harmful to this person, her voice popped on. Like immediately it went on. And she's like, I can talk. And it basically, when the feelings go through and remove the tension, like I say, all the way up those spine level, all the way up the physical levels, it's diagnostic and therapeutic. See, so diagnostic means that now the vocal spasm has stopped. There's emotions that have been felt to help us understand it. And it brings a therapeutic benefit. And we aim to try to figure this out in the first session if we can. Sometimes we can't. Sometimes this is not effective. This isn't a panacea. And people have multiple causations as well. But sometimes it's kind of dramatic when people can, come in and unable to speak and go out able to speak. It's kind of interesting that she was literally locked to be able to say anything about what had happened, because all these feelings were coming up from early childhood trauma because of the current relative who was threatening to her. So those are two examples of the muscle tension. So what is it then that coming up, we talk about emotions and such, like one thing with the research, and this is all out of McGill University's research, Dr. Davenlu out of McGill did this main work, is the somatic pathway of emotions. So the somatic pathway of a loving feeling is generally a warmth in the chest, an urge to embrace, an urge to smile, and to have eye contact. Versus rage has this rising heat energy up the chest, goes up to the head, down the arms, and an urge to do something with the hands typically. Versus guilt about the rage. Guilt about the rage has hard, solid waves. It's in the upper chest, affects these neck muscles as well. And the person is constricted and has horrible pain as if they just murdered a loved one. Like they're literally seeing it on the office floor, and this guilt is coming through in hard bursts of with tears and horrible remorse coming through. And it's like waves like this. This is a sound wave of a person experiencing the guilt. These waves that last a minute or more, and then another one and another one. Versus grief. I mean, grief is a painful feeling in the chest, and there's waves, but it's not the same type of quality. It doesn't hurt the neck. And the person is thinking about what they lost. Somebody died, they lost a bond with someone. It has a different thought content and a different physiology. So these things here are quite distinct. And, you know, if you ask an average person on the street or ask your average patient, how do you feel when you feel anger? They're going to describe unconscious anxiety 9 times out of 10. They're going to tell you they can't think, they get nauseous, they get tense, their heart starts to pound. They don't experience clean emotions because 9 out of 10 of our patients have been traumatized, and their relational system has been distorted, and their emotional system has been blocked, so they have unconscious anxiety, one of these 3 channels. So check it out when you sit with your next patient, if you're not already doing this and already seeing this all the time. So from the treatment process, what is it we're doing here? Is the defense is a product of the anxiety. And what we're doing is we're focusing on the feelings and doing something to help them not avoid. Think about it as exposure and response prevention. You activate and you block avoidance somehow or other. Help them experience the feelings, go through the body, including positive feeling, grief, rage, guilt, in whatever sequence they come. Help them feel those with us in the moment in the room. And when the feelings are felt, the anxiety cuts right down, and therefore the defense is cut right down. The other thing you're doing when you activate these feelings is you're activating memory and emotion systems from this past attachments. So you go to the point when the anxiety drops and the defenses drop, that the person's memory banks are now right online, and they can see what emotions were getting activated with you. Sometimes it's very specific in the form of the image changes over. So, another video example is a guy came in, he had a strong positive feeling. He's doing better, session 6, no longer depressed, and positive feelings coming through. I asked him what that's like, this positive feeling, how do you feel that? And he has this warm feeling in there within himself. And then within a minute of feeling this warm, positive feeling, there's another emotion come right behind it. Is anger's coming really quickly, right with the positive feeling with me. This rage energy is coming up. It gets into his shoulders to his arms, okay? And he feels it go through his body with an urge to grab and choke, okay? He just feels it and tells me about it. And when he goes to the choke, he's looking and he sees his sister when she's a little girl and was a component of abusing him. So he's looking at me, but he doesn't see me. It is his sister. And then he feels that anger go through with a lot of guilt, as if he killed his little sister. Okay? So that is like this memory and emotion system kicking in a dominant way. So this, I mean, we have different terminologies for this, but basically you're going from an inhibitory state to an open memory and emotion system being dominant, more limbic operations in a sense, here more inhibitory processes. Using, if you want to call it a fancy kind of exposure response prevention thing, I'm happy for you to say that, because it ultimately is, with different elements that you need to bring in. So that's what it looks like with the nice tense person who is solid and has nice anxiety tolerance. It's a direct move. Ideally, you know, it can be 15, 20 minutes, half hour into the first interview. And they'll, on average, feel significant symptom reduction. So, so that's that process with solid patients. With patients who need capacity building, like the smooth muscle I described, you know, seeing the cardiovascular, urology, GI specialists with all this spasming smooth muscle, they have a threshold whereby the emotions don't, below which they're tense, above which they're getting nauseated and smooth muscle. So there's a threshold where you have to try to work below. And to get these same dynamic forces of memory and emotion activated, you have to go in a gradual way or a graded way. So it looks more like this. You kind of bring up the feelings. When they get nauseated, you intellectualize, recap, summarize, focus on the body a bit until they're settled and they're tense again. Then you bring back up. You reactivate up until they get nauseous again, or just on the edge of nausea. Then you bring it back down, you go up, down. It's a graded type of exposure. It's done in vivo in the office. It is, you ask about scenarios with you in the here and now, and also current examples in the recent times, and you go back and forth between those, and gradually those same forces come in, and the memory systems kick in, and the images and the links kick in. But just doing this, by the way, without any past emotions coming through, people get better. Because think about it, if the person's threshold is way up here, this is way better than down here. Person with severe irritable bowel, they can't do much. I mean, it's terrible. They can't drive a car anymore because they're afraid to get stuck at a light and get diarrhea, so they can't do much. Here, this is only like a bit of exam nausea. So it's a huge difference here without anything being felt. And that's my point here, is that you don't need to unlock anybody's unconscious to get symptom benefits. Ideally, if we can help them understand and process some of those attachment feelings from the past, it does make a difference on outcome. I didn't put the slides up on that, but if they can have a significant, like what's called this unlocking process, their symptoms improve more, their healthcare use improves more, and we've seen that in 4 studies. So we aim for it if the person's able to and wants to. Okay, so that's the capacity building with repression and with smooth muscle, and then you have motor conversion. Same thing with motor conversion is, when the feelings come up with a person with motor conversion, their arms get weaker or their legs get weaker. Like they go floppy when they hit that threshold. So over the threshold, their arms don't work well, or their legs, or their neck doesn't work right. The muscles tone has gone down. So you're going to work in the same graded way like this and help them understand that intellectually, and that makes the anxiety go in the muscles, and then you rise it up more and more, and gradually they can have strong arms, and they're not afraid of what those arms are going to do. See, because that's what this is about, their fear of having a powerful body and anger. They're frightened of it. The body shuts down. So you're going to gradually, in a kind of, again, graded way, help them get there, get rid of the fear of feeling strong muscles, with emotions. Okay. And the cognitive perceptual field, apologies for my non-COVID cold here. Not that I'm going to be able to give you COVID through this thing, but is cognitive perceptual disruption. I mentioned this here. These patients can hallucinate when they're anxious. They can have small psychotic moments and get mistaken for psychosis. And that's really important to know too, because you're not generally going to require pharmacotherapy here. It's going to be psychological, anxiety reducing approaches. They end up on short stay sometimes because of that, though. And some on antipsychotic. And historically, a lot of people with this would have been called schizophrenia in the 60s and 70s. So these are neurology, and see psychiatrists see us too. So with that population, that includes, by the way, patients with borderline disorder, the full-blown borderline syndrome, are treatable with this approach, but it's longer. It's ideally it's a year or 2 years, but they can make gains with a 20-session time-limited approach too, on average. That's what we do these days, is a 20-session time limit because of our staffing being limited. So what do we do here then? This is what this population tends to look like. At a mild level of fragility, they can tense up and intellectually see things. Above that, they can get nausea, and above that, they can get confused. And above that, they can get afraid with projective processes. So a mild fragile person can function decently. Moderate fragility, they get a lot of fear, a lot of projective processes, hospitalization, self-injury, and such is common. Dissociative episodes, functional seizures can be here. And the more severe fragile population, would be frequent, think of borderline syndrome and severe dissociative disorders. And also think of people who get stuck in projective processes too, with distorted perceptions of various types, fragmented character structure inside. So treatment-wise, here you're going to build reflective capacity to overcome these split processes and projective processes. You're going to be reflecting. By the way, to me, I don't know any treatment work for this population doesn't do things that are very similar at the beginning. You're building this reflective processes. Be able to observe, be able to intellectualize, be able to notice things, be able to observe the body. And then they move over further here, where they have a little bit of room to land and can stand on this area of tension where they can think clear and look at what's going on. And then you can start to do this graded work. Be able to start to identify emotions and start to tolerate anxiety better. And then they start to, when you get over here, they start to be able to experience some of these feelings. So if you take functional seizure, person with functional seizures, they're down here, they're having frequent full-blown episodes. Then when you get over here, they start having fewer full-blown episodes, but they start to become more aware of brain fog episodes where they're a little cloudy, but they don't get a full-blown seizure. And then over here, they get rare events of seizure type of thing, but they have more of this brain fog, and they start to get more muscle tension, muscle weakness. So they get more repression symptoms. And they start to be able to interrupt episodes. And then when their capacity is up here, they get rare or no brain fog and weakness and start to feel feelings. So you move your way here to here, you can move there in a handful of sessions. When you get to moderate, you're maybe 20 sessions. When you get to severe, it might be a year. Depends on how severe the level is. And, again, it's reflective processes. It's what makes sense is help them be able to do something to observe in an integrated way what's happening within themselves and observe what they project out on others too. It's largely a cognitive and reflective process here. Okay, and the last type of symptom is, before we do questions, is sympathy symptoms, where the person has the same symptoms as what the rage wanted to do. So for example, if they had a rage that wanted to stab someone in the head, they get stabbing headache. And if they wanted to choke someone, they get a choking anxiety attack. Their neck feels like there's a hand on it. If they wanted to crush someone's chest, they go to emergency with crushing chest pain. But sometimes it's very much more specific than that. This patient with sharp pain in his eyes, when the feelings of the rage came through, he wanted to stab one of his parents in the eye with a pencil. Very specific. And then when they feel the feeling, the symptoms go up. That symptom stops immediately in that moment, and they can see what was going on. It's due to guilt. It's due to caring about the other person. It also has an effect of being self-punishing, because some of these symptoms are horrible. For example, a patient who was getting burning feet, and no, they couldn't find a reason for it. And when it was really disturbing, this burning feet. And when one of the breakthroughs of the rage came, it was to stick the husband, who was chronically critical, onto a fire with his feet burning. Okay, horrible, terrible thing to go through. And she felt that, and a terrible guilt came. And then her pain stopped on her feet. So it's tough feelings to face. But I mean, there's no reason for someone to suffer for something they didn't do. I mean, this is my thought on it. Why someone got to suffer when they never choked anybody, they never hurt somebody's head, is to help them start to feel, understand things, and undo the need to hurt themselves in some way on an unconscious level. So those are some thoughts. This sort of general framework, sometimes capacity building, sometimes more just directly helping them start to feel things. Have to handle avoidant defenses that can be really tough and can undermine therapy of different kinds. And is to start to feel, and not just to think and intellectualize and all that, is to begin to start to feel things, including all these complex feelings. And this applies to a lot of patients. You know, think about your psychiatric patients. How many have irritable bowel syndrome? How many have chronic pain and headaches? And even in the setting of a person with bipolar disorder, they can have all of this. You can have a person with psychosis episodes in the past that has some of this. And certainly depression. Depression, there's a lot of smooth muscle involved in most people, and sometimes a lot of confusion as well. So maybe something to think about when you sit with your patient is, when you ask about emotions, what does it do? Do they have anxiety that shows up in any of these channels? And if so, what might you do to help them with it, or what might someone do to help them with the anxiety channel problems that's going to contaminate your treatment? Okay, so I think we'll go to questions here. Okay.
Okay, so I see a bunch of questions coming in. Thank you